Hello, 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 everyone. Happy Friday. Welcome to yet another VMR. It's a 50-50 shot whether you will get the full treat of Prof. Rez here today or whether you'll be stuck with me alone. But worry not, because we have Drew here. I met Drew many moons ago when he was in MS3. Is that right, Drew? MS3?
Like the very, very tail end of my MS3 year.
You can count on Drew to be as precise as anyone I've ever met. Exactly. And we got to hang out many, many, many moons over VMR. And I think Drew is now making a comeback in terms of presence on VMR. I think this is your second, or if not third, case presentation in the last
Second.
month. Is that right?
It's second in the
Second?
last month.
Uh, what
Yeah.
have you been up
So,
to?
uh, being med peds means being busy. So
Yeah.
a lot of prep and all that stuff. And so just a bit of background for everybody for anybody who I guess doesn't know me. I'm Drew. I'm a third year medicine pediatrics resident over at WMed in Kalamazoo, Michigan. We currently in this basically this year has just been busy, 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 but um, future plans I'm in the process of getting ready to apply for pediatric hospital medicine fellowship uh, for this upcoming match cycle, and with the intent of doing combined hospitalist work, both
That's
adults
awesome.
and kids.
That's wonderful. Congrats.
Yeah.
That's really cool. It's great to see have been part of your journey along the way, and it's great to see you come hang out with us on VMR. I'm hoping that your case is not a pediatric one because I
Oh,
would have no idea how to take care of that patient. But yeah, really, really excited for it, and gratitude to Tansu and Francisco. I combined your names for a second there. To Tansu and Francisco for steering us today. And we'll see if Profres is able to make it. He told me an hour ago is a 50-50 shot. Um, if he's unable to make it, we'll use that time to collect everybody's thoughts through breakout rooms.
mhm.
But Drew, we're ready to rock and roll whenever you are.
Yeah. I will already tell you that no, it's not a pediatric case. It's a 30-year-old lady. So, just waiting for the whiteboard to come up. Good. All right. Um, so key concern is dyspnea. I'll go into a little bit more detail because this is probably going to require a little bit. So 30-year-old lady who comes in with 2 days of dyspnea, abdominal pain, chest pain, nausea, vomiting, and lightheadedness. Um, Patient had previously been admitted to the hospital where this case is taking place about 2 months prior. Um, well, actually, 2 months prior for because she also had, in terms of her medical history, she has cirrhosis uh, and diabetes, both related to alcohol use. Um, Last admitted 2 months prior for decompensation of her cirrhosis, and last admitted around 4 months prior for an episode of DKA. I will note that prior to the start of her symptoms, she did have 2 episodes of drinking in the week prior to admission. One 7 days prior, where she drank about a pint of liquor, and one about 5 days prior, where she had about a half pint of liquor. And for the last 2 days prior to admission, she hadn't been able to tolerate any oral intake. She was nauseous, vomiting, had generalized body aches. She also had rapid breathing and dyspnea over the same time. Had some chest pain, which was sharp, localized over the upper chest, didn't radiate, was constant, didn't have any change with either exertion or rest. And her abdominal pain was similarly localized to the right upper quadrant, was stinging in quality, wasn't affected by appetite at all, as the patient wasn't able to eat. In terms of other symptoms, constipation with her last bowel movement several days prior to admission. Uh, I mentioned the vomiting. She had 1 episode prior to coming to the ER where you're seeing this patient. Some chills, headache, right hip pain, for which that was basically secondary to a hip fracture about a month prior, and bilateral foot pain consistent with her diabetic neuropathy. But she didn't have any fever. She didn't have any focal weakness. She didn't have any dysuria, any polyuria, or hematuria. Um, is on insulin but didn't take any of it for the last 2 days prior due to not being able to eat. Also has not taken multiple of her other medications in the last month prior to admission for otherwise unclear reasons. And yeah, basically she was taken to the ER because her shortness of breath was worsening. But she is able to give most of this history with the assistance of family there. So I guess I'll go into the southwest corner a little bit
I think that was
just
a
to
lot.
round
Why
it
don't we
out.
stop here, Drew? That was a lot of information. I think probably a
Yeah.
lot more than I can handle in a bolus. So why don't we just stop here? Because there's almost certainly something that I would be thinking about now, um, and and I think that the tension right now is what do we, how do we begin to understand what this problem is?
Hmm.
And I think it's actually really tough to do that, in large part because as you're sharing with us, she has a very rich medical history
Hmm.
dominated by two very large and powerful conditions, which is cirrhosis and diabetes. I think the first thing to explore that you mentioned is that the connection of alcohol to cirrhosis is a very robust one. Um, the question is that connection bulletproof? And I would say that in a 30-year-old person, the ability for other conditions to masquerade under the label of under the label of alcohol-related cirrhosis is very important. So, the amount of alcohol required to develop chronic liver disease is usually a large amount. And it could be such that this person has consumed enough alcohol in such large amounts by the age of 30. But given how much is needed, you have to sit there and wonder, is there an alternate contributor to that cirrhosis? The same is true for her diabetes, in large part because the connection between alcohol use and diabetes is also uh, uh, not a robust one. It certainly can be through the connection of chronic pancreatitis. So all this to say, I think when you have a 30-year-old person who has two dominant conditions, cirrhosis and diabetes, it's so easy for them to be attributed to her alcohol use through the connections we talked about, but being open to the possibility that she has type 1 diabetes unrelated to her alcohol use and being open to the possibility she has another condition contributing to her cirrhosis is really important, especially when, as Dhruv is trying to share with us authentically the story is all over the place. It's everywhere. There's chest symptoms, abdominal symptoms, nausea symptoms, numbness symptoms, hip symptoms. So knowing where you stand in terms of what you take for granted and when you take as assured is really, really important. Um, I think this case is a great reminder of the importance of recognizing the value of a point of care glucose. Point of care glucose is often emphasized in patients coming in with neurological symptoms, but it's equally important in patients with abdominal symptoms as it may reflect DKA. And so in this person, I think what would happen immediately is you would try to figure out what is signal and what is noise. And you would do that, I think, by trying to establish what you can verify on exam that the patient is reporting. Is the abdomen tender? Is the lungs compensating through excessive gas exchange in some way, shape, or form? Um, and is there anorexia suggesting abdominal issues? So right now, I think this is utter chaos right now in terms of understanding what's going on. And I think that the goal really is to begin to simplify this issue and understand it better. And the way I would go about doing that is to see what physical exam findings are apparent that can attach to this history. Because we have head to toe findings and we'll have to see which ones really stand on an exam. So I'm not at all sure of what the foreground is and what the problem is. And I'm not at all sure really what the background is. So I'd be very, very careful to try to see what findings on exam can merge those two things. But I think the first thing I'd want right away, in addition to an EKG for her chest pain and an exam to understand what's going on, is a point of care glucose to see if she's in DKA. All right, Drew, what a start. I feel like I'm in the washing machine tumbling, and hopefully we'll have a good end to the cycle and have some clarity about what's going on.
Yeah, and this is just the start of a very intense watch cycle, if you will. Um, we'll go into We'll do southwest corner, and then I'll also give you her physical exam, along with those couple of other quick labs. Um, her medical problems include cirrhosis of the liver, which was diagnosed about 6 odd years prior to admission. Um, she also has depression, gastroesophageal reflux disease, and alcohol-associated pancreatitis, which was bad enough that she now effectively has endocrine pancreatic insufficiency and type 1 diabetes as a result. In terms of medications, she's on uh, cyproheptadine, folic acid, gabapentin, hydrocodone, and acetaminophen for pain, ibuprofen, lactulose, uh, basal bolus insulin regimen, spironolactone, thiamine, and duloxetine. Although a lot of those medications she had not been taking prior to her admission. In terms of family history, not really much except for alcohol use disorder in her dad. In terms of social history, lives with her mom and her sister. And as I had mentioned before, has had multiple prior hospital admissions for similar issues. Smokes about a half pack or about a pack a week of cigarettes. Has about 8 shots of liquor per week. Although, as I did mention, her last drink was about a half pint of liquor 5 days prior to her admission. And also uses cannabis, which is legal in the state where she's being seen. And has also had been doing a bit better in terms of getting health maintenance stuff, but not very, but yeah, not very much. And no known allergies either. Are we good to get the physical exam? All right.
Yeah, let's do it.
All right. So vitals. Temperature of 35.8. Heart rate of 117. Blood pressure of 117/82. Respiratory rate of 28. But adding 100% on room air. And on her exam, trying to be as comprehensive as possible, you find the patient in moderate distress. He's covered with multiple blankets and is actively being warmed, and she is notably cachectic. In terms of her HENT exam, she has frank conjunctival icterus without any pallor, but otherwise her eyes are fine. Her oral mucosa are dry, but her dentition is fair. No other cervical lymphadenopathy or thyromegaly, and no JVD that was noted. Cardiovascular wise, he's tachycardic, but in regular rhythm with normal S1 and S2 and no other murmurs or extra sounds. She is tachypnic with deep inspiratory effort, and her lungs are otherwise clear. She was lying down when taking that SpO2. Um, Abdominal exam, she was mildly distended, but her bowel sounds were normal active. She was soft, tender to palpation at the right upper quadrant, but no hepatosplenomegaly or any other masses. Neuro-wise, normal. And extremity skin-wise, um, he's just frankly jaundiced. And for the uh, labs that we wanted to get like immediately, I think I'm trying to remember, Robbie, what you had wanted. I think it was like a point of care glucose, and I think that was the big thing at the moment.
Yeah, whatever you had planned, Drew. Yeah,
All right.
whatever you.
So, well, I'll tell you that her I'll give you the glucose that was on her BMP that we initially got. 927.
Yeah, unfortunately, that's yeah, very very high. Did
Yeah.
you want to stop here or?
Um, I guess since let's stop here now. I'll give really I think actually we may be able to get it down to yeah. No, it'll still be 4 aliquots before I get the final diagnosis, but um yeah. So let's stop here for now.
Alrighty. Yeah, I think that this exam is really, really helpful because I think it really drags your attention to focus very hard about the liver. Um, when we see such extensive icterus and we translate that into the presence of jaundice, the question is, what is the nature of that jaundice? Is it direct or indirect? And here, both her medical history related to cirrhosis and the depth of the of jaundice really prioritizes an intrahepatic cause. And so I think that your operating problem representation would be the concern for decompensated cirrhosis. The reason that frame is really important because the presence of cirrhosis really influences what can subsequently happen to the liver as it decompensates. So, for example, the rate of acute liver failure in patients with cirrhosis is basically zero, in large part because of the relative deficiency of hepatocytes. And so here, the depth of her jaundice, while waiting for the labs, really suggests that she has decompensated cirrhosis, which has its own frame. But I think you want to confirm that by seeing the labs and seeing that in fact the bilirubin is elevated. The remaining questions really are why is she so cachectic, which I think you have a prominent answer for. She has a severe consuming disease with cirrhosis and probably many risk factors for malnutrition related to her depression and alcohol use, and possibly with her pancreatitis malabsorption. So there's really not much momentum to look for cachexia, but it is a reminder anytime somebody has low weight to screen for HIV, which is the only test necessary in everybody who has low weight. So I think the problems so far um, are worrying about what causes decompensated cirrhosis, and then the other thing that you found is glucose this high. Now, a glucose this high in a patient with type 1 diabetes is very, very unusual. The reason that's the case is in most patients with type 1 diabetes who get hyperglycemic, they usually do so because of complete insulin deficiency. And that complete insulin deficiency results in ketosis. And so, why is that important? Ketones usually cause really bad abdominal pain, nausea, and vomiting, and force the patient to present much sooner than patients who don't have ketone formation and result in high glucose, as is seen in HHS. So, in type 2 diabetes, which is out of control, there's still enough insulin around to protect against ketosis, allowing the patient to reach much higher levels of glucose. In stark contrast, in type 1 diabetes, when insulin is completely deficient, um, the um, the presentation is much sooner. Now, these mental models of type 1 and type 2 are actually really just mental models. There are patients who have varying degrees of insulin resistance and insulin deficiency. And so here, I think that the fact that her glucose is so high argues against her diabetes being only from insulin deficiency and a component of insulin resistance. But either way, I think knowing her ketones will be really, really important. So I think there any emergent things to do right now? Um, Maybe. And that comes with the final problem, which I think Drew is painting very well, both in terms of the vital signs and then also in terms of her behavior, which is she's wrapped in blankets warm and she's hypothermic. There are two leading causes for hypothermia in all comers, and that's sepsis and environmental exposures. And given her severe alcohol use, it's not impossible to wonder whether she had environmental exposures while intoxicated, but also really, really worried given her cirrhosis about the possibility of an infection. There are many other ways to think about hypothermia, and you can think of it quite simplistically as either a temperature generation issue or a temperature loss issue. And in terms of her temperature generation here, she's at many, many reasons for it, including her cachexia and lack of muscle. And for the loss here, I think environmental losses and or losses through vasodilation from sepsis are the most important. So what's the emergency here? The emergency is that it really is meeting sepsis and SIRS criteria, which is that she's hypothermic and tachycardic and she has an immunocompromising condition. So what would happen as a result? We would probably empirically treat her with broad spectrum antibiotics right now, get blood cultures, and move very quickly towards a diagnostic paracentesis to look for spontaneous bacterial peritonitis. So what's happening before the labs come back? Warming, as Drew is already doing, insulin, fluids, and here the choice of fluids would be an interesting one. I imagine that she has a large amount of fluid deficit based on her vital signs and the degree of her glucose. So you would certainly be thinking about using albumin given her cirrhosis, but the evidence for that is plus minus. And regular old crystallite is probably okay. So broad spectrum microbiological analysis, a diagnostic paracentesis, broad spectrum blood cultures, fluids with the possibility of the use of albumin, and insulin. And as Drew painted on from very, very early, this is a very, very sick person with a lot going on. And even before the labs come back, you're doing those five things. So yeah, I am certainly very worried, and I'm really curious, Drew, of where this case goes next.
Yeah, so someone said check lactate ASAP. I'll get to that. Um, so labs. Let's start with the CBC. White count of 11 and a half. Hemoglobin of 9.5 with an MCV of 102.2. And platelets of 142, which is normal, surprisingly. For BMP, sodium of 120, potassium of 2.9, chloride of 67, bicarb of 4. So that gives you an anion gap of 49. BUN was normal. Her creatinine was 1.04. Her baseline is like 0.3. Her calcium was 8.4, and her ionized calcium was 3.9. I don't think we got a mag at that time. Let's see. AST of 101, ALT of 22, alk phos of 407, albumin of 3.4. Her bilirubin was elevated at 10 with a direct of 7.4. Her ammonia was elevated to 187. Her lipase was chronically low at 5. Her Blood alcohol was negative. A urine drug screen was only positive for opiates. But that's to be expected since she takes Norco, hydrocodone. Um, Her Tylenol level was negative. It was 7. And then the kicker, or actually, I'll give you a blood gas, arterial. pH is 7.18, PCO2 of 9, PO2 of 156, base deficit greater than 15. And then her beta hydroxybutyrate was 3.5, and her lactate was greater than 20. And when repeated in 4 hours, even after adequate resuscitation, it remained the same, greater than 20. And I am going to leave it there.
Thank you, Drew. Um, I just have one clarifying question, and then we can go to breakout rooms for the teams for the groups to think about this really interesting lab abnormalities that you have, many of them. I'm curious, was there a serum lactate at the same time? I know this is a lactate off the ABG.
No,
Uh,
no, lactate was serum.
I see. Gotcha. Okay. All right. So, um, to summarize, you basically have a mild leukocytosis, a macrocytic anemia, a very high glucose, very high bilirubin, very high ammonia, um, and a very low bicarb with a very high lactate that persists despite fluid resuscitation. Okay, team, let's think about this as groups. So we created breakout rooms. Drew, feel free to join if you like as well and participate in the conversation. Get your
Absolutely.
thoughts together and learn from each other as much as you can. And we'll reconvene in like 3 or 4 minutes to discuss these many, many, many problems that we have that Ruth has given us. All right, see you all in a few minutes.
I think Emil wanted us to see about a, yeah.
What's that? Too late. Uh-oh. Welcome back, everyone. I really hope you've had helpful discussions. Um, and learn a lot from each other. I think this case is really, really interesting, and I think now you're getting a little bit of momentum, at least to know what to begin to address it as. So I'll just share my thoughts that I think that in this case, these patients are usually very, very complicated, and we have them problem listed, but it's always about what the problem number one is here. And I think to identify every other problem first. Concern for infection. This person is getting broad spectrum antibiotics and getting all the infectious testing under the sun. And for concern for decompensated cirrhosis, that triggers a very specific workup looking at portal vein thromboses, infections, and GI bleeding. But the main abnormality here, and the abnormality that we got to talk about. Oh, hello, we have a little kiddo on the phone call too. Yeah, there we go.
Sorry, that
Uh,
was my sister.
no, no worries. Uh, the main abnormality here is focusing on the lactate. Now, the validity of this laboratory abnormality is not in question because of the consequences on the bicarb. So we have a high lactate and we have a low bicarb, and that essentially is explanatory. So this case all becomes about how we systematically approach a patient with a high lactate. You'll see that there's a CP solver schema on this topic, and it's really important for everybody to know about it because lactic acidosis is divided into two types, type A and type B. Type A is meant to say that the lactic acidosis is being generated as a result of insufficient oxygen use in the tissues. Insufficient oxygen use in the tissues. That is usually as a result of low perfusion of the tissues, which can be a systemic problem, i.e., hypotension, or can be a focal perfusion issue like mesenteric ischemia. Type A lactic acidosis can also occur not because the oxygen is not being delivered, but because it is absent in the blood, usually as a result of methemoglobinemia or carboxyhemoglobinemia. Finally, you can get tissue ischemia, not because there's not enough oxygen getting there, but there is a rapid increase in metabolic demand, such as in patients who are seizing or shivering. So remember this, type A, this will be, by the way, for those of you who are going into residency next year, this will be like many, many patients you take care of. What is the cause of lactic acidosis? We prioritize the oxygen not being where it should be, either because of systemic hypotension, like shock, focal hypotension, like mesenteric ischemia, low oxygen, usually as a result of methemoglobinemia or carboxyhemoglobinemia, and then increase tissue demand outdoing its supply. Type B lactic acidosis is a whole world of conditions that result in excessive lactate generation that have nothing to do with oxygen delivery. And that could be because of a mitochondrial issue, because the oxygen is there, but the mitochondria cannot use it. And that mitochondrial issue can be a genetic disease, but more often it's the result of toxins, usually alcohol, or medications like propofol, but can be the result of nutritional deficiencies, most notably thiamine deficiency. So mitochondria not working is a really, really important arm to think about lactic acidosis generation. It also is possible that you generate lactic acid independent of perfusion or independent of mitochondria because you are in a rapid glycolysis state. This is, you all will do this when you give your patients a beta agonist like albuterol that triggers glycolysis and triggers a lot of lactate generation. So that occurs in patients who are given beta agonists like albuterol or who take beta agonists like caffeine or methamphetamine, or who produce beta agonists like patients in a pheo who have pheochromocytoma. There's a really, really important mimicker of lactic acidosis, which is a false positive lactate, and that's ethylene glycol toxicity. That occurs in patients for whom the ethylene glycol messes with the lactate lab assay, but it usually messes with the serum, the ABG lactic acid assay. So on the ABG, the lactate will be really high, but the same time, if you measure the serum lactate, it'll be low. So that is like the whole world of lactic acidosis. Which parts apply to this patient? One, she does not have systemic hypoperfusion because she's awake and talking and her blood pressure is normal. But could she have focal hypoperfusion causing mesenteric as a result of mesenteric ischemia, explaining her abdominal pain? For sure. Could she have methemoglobinemia? Unlikely because she's standing 100% on room air, but could she have carbon monoxide poisoning? Possibly. But usually the cutaneous features of that disease would also give you a clue. So of the type A hypoperfusion, the only reasonable thought here is the possibility of acute mesenteric ischemia. In terms of the type B, does she have a genetic mitochondrial issue? Probably not. Does she have toxins on board that can impair mitochondria? Absolutely, the alcohol. Does she have any medications? Not that I can see. Does she have deficiencies? Absolutely. And a big, big, big risk factor here is thiamine deficiency. And that giving her thiamine might be life-saving. It's probably really important to make sure that you don't have a beta agonist on board mimicking the situation, be it methamphetamine or caffeine or anything like that. And then finally, if you notice a discrepancy between the ABG lactate and the serum lactate in this patient who might have accidentally or deliberately ingested ethylene glycol. So what would I do next? I think I would have a very low threshold for cross-sectional imaging of the abdomen and giving this patient empiric thiamine therapy and checking a eutox to make sure there's no amphetamine on board. Very, very sick patient with a lot to do, but the lactate is really, really grabbing our attention. And hopefully it'll melt away with some thiamine. And I hope this is not another devastating diagnosis in a young person, but mesenteric ischemia is a very reasonable possibility here. All right, Drew, what do you got next?
So, about that, did want to give a couple of other labs before I gave sort of the clincher. Her INR was markedly elevated. It was like 3.8. And her PTT was also elevated at 50 seconds. Um, just trying to take a look and see if there was anything else. We got blood cultures and multiple of them over the course of her admission. They all came back negative. Um, so in which case, the imaging. We got a CT abdomen pelvis and a chest X-ray, and chest X-ray was fine. We unfortunately did not get an EKG on admission, which probably should have. But the CT abdomen pelvis showed essentially enterocolitis, pneumatosis in the ileum, hepatic cirrhosis with associated portal hypertension and small ascites, and wall thickening of the distal esophagus, which may reflect esophagitis. So that's the last thing that I'm going to give.
Yeah, I think just for the sake of time, because I have to leave a little early for rounds.
Yeah.
I think the presence of pneumatosis is very, very concerning. What pneumatosis means is there's air in the bowel wall. This is essentially a periperforation. It is true that you can get air in the bowel wall for benign reasons, and that can occur in situations where you're fermenting a lot of gas in the gastrointestinal tract, usually in patients with small intestinal bacterial overgrowth. And that has a specific term that's called pneumatosis cystoides intestinalis. This is not a scenario that diagnosis is invoked, and essentially, we're really wondering why this patient has her GI barrier compromised. So, in summary, when you see air in this bowel, the two possible ways it can get there is through excessive air generation in the lumen, causing high intraluminal pressure migrating through the wall as a result of excessive pressure. More likely and more ominously is the possibility that the bowel wall is compromised and weak, and the gas is not getting there through excessive pressure, but is getting there through a weak wall. And in this patient who has abdominal pain and other signs of hypoperfusion, namely the high lactate, I think this would be very, very concerning for the possibility of mesenteric ischemia. Most mesenteric ischemia is arterial, 85%. And within arterial, there's a 50-50 split between embolic arterial disease, like from AFib or endocarditis, and the other 50% is local arterial disease, usually as a result of atherosclerosis or dissections. If it's not arterial mesenteric ischemia, it could be venous. The idea being that the portal vein or its branches are thrombosed, and that thrombosis causes venous congestion, compromising the bowel wall. This patient is at risk for both conditions. Her alcohol use puts her at risk of atrial fibrillation, which puts her at risk of atheromembolic disease to the gastrointestinal tract. But her cirrhosis puts her at risk for cirrhosis-induced portal venous thrombosis, which can cause secondary ischemia. The CT needs to be protocoled for both an arterial and venous phase to see whether or not there is gut ischemia. That would be my leading concern in this patient, and this carries a significantly a significantly morbid possibility. So very, very tricky. What I would do next is consult general and vascular surgery to see what their take is on this CT result.
Mm. Yeah. So just to give closure to the case, ultimately the patient was diagnosed with acute pancreatitis, and she was treated with ceftriaxone and metronidazole. He did have to get transferred up to the ICU because she basically was in hypovolemic uh, and distributive shock. Um, C. diff testing was sent. He was colonized, but not positive. Um, and ultimately was able to be weaned off of pressors and transferred back to the floor, and was started on rifaximin and lactulose for hepatic encephalopathy. Um, did get a paracentesis, and there were no signs of SBP. But ultimately, given that her MELD score was rising and bad, um, and I know that a lot of people are asking about antibiotic coverage. We do not use ceftaz in our hospital. I know that some do, and I think actually she was broadened out. I think to Vanken. I think she was broadened out to vancomycin, if I remember correctly. Um, but yeah, she ultimately had to get transferred to a liver center, and ultimately was uh, was unable passed before she was even able to make it to the possibility of a transplant. So
True, but
unfortunately a sad end to this case.
yeah, I think unfortunately it's not a surprising end, but a very, very unfortunate series of events. If I could do a cognitive autopsy and reflect on not just the diagnostic reasoning, but I think what I think is a sequence of events in this case, it actually doesn't begin with this. It doesn't begin with this patient. It begins with the family history of alcohol use. And I think and when you reflect on the presence of alcohol use disorder in young adults, you'll very frequently find a very specific reason or set of reasons why an unfortunate young adult gets into the spiral of such severe alcohol use that it triggers cirrhosis at the age of 24 and triggers chronic pancreatitis enough to cause type 1 diabetes. So this is not a story that begins with this person. It begins with the environment that she's in, and also maybe potentially a genetic predisposition towards absorbing some of the features of that environment. Um, and I think when you have your liver down and your pancreas down, you can really get sick very, very quickly. Now, what did she have? I think ultimately is a conversation we've had in the CP Solvers Academy many, many times. The the crux of her acute clinical syndrome, I believe, has to incorporate her lactic acidosis. Everything else is a consequence of her underlying vulnerability. Her jaundice and her hyperglycemia are both features not of the current syndrome, but consequences of her pre-existing disease and the pre-existing disease of cirrhosis and diabetes. What is the thread of the new insult? A lactate of 20. So now the question is, why does she have a lactate of 20? And I think that you're pointing, Drew, as you accurately did, to her abdominal findings. So this case, in my opinion, is all about an accurate assessment of what the differential diagnosis of pneumatosis is. And again, pneumatosis can be the result of high pressure in the lumen, usually from gas-forming bacteria and small intestinal bacterial overgrowth, not the case. This case is all about why is her GI wall compromised. And I think the possibilities are the two I's, infection or ischemia. And many of the Academy members will recognize this conversation. The findings of infection, ischemia, and obstruction on a CT scan are almost identical. And unless a radiologist, this is a really cool study, unless the radiologist is asked specifically to help, is given guidance that the team is thinking about mesenteric ischemia, they will miss findings of mesenteric ischemia in up to 25% of patients. For me, the acuity of the disease and the disproportionate lactic acidosis and the complete absence of diarrhea, and in fact, the presence of constipation in this patient are all red flags layered upon a markedly elevated lactic acidosis to suggest that I would be leaning much more to the ischemia here rather than the infection. Either way, what would happen in real life? All patients with bowel ischemia are treated for bowel infections because ischemia can beget superinfection. So it doesn't really matter what we believe about the infection hypothesis, whether it's the leader of the issue or a consequence. It has to be treated. The thing that matters is having your eye to the possibility of ischemia. And I think here, the high lactate, the evidence of small bowel and large bowel involvement, along with the acuity and morbidity that this person ensued and the absence of diarrhea, are all very, very characteristic features of mesenteric ischemia, which is very, very commonly overlooked, if not specifically queried for. Um, and she has so many reasons to have it, including embolic disease from AFib, and portal venous disease. Ultimately, I think, again, even this reflection doesn't begin and end with this patient. Her medical history makes her too vulnerable to survive an insult that results in a lactate of greater than 20. So I'm really sad to hear this story, Drew. It's a hard one to there's a lot of learning here about thinking about signal versus noise and high lactates and ischemia versus infection, but ultimately a tragic story of the devastating effects of this person's environment and the consequences thereof. I'm
Yeah,
curious if you had any reflections you wanted to share, Drew.
there's a couple of things. One, for those of you who were saying, talk to surgery and all of that, we did. We consulted them. They essentially said, take care of the DKA, take care of the decompensated cirrhosis, then we can talk. Ultimately, ultimately the pancolitis and all of that got better enough, but really the main thing that ultimately happened was that she went into just florid acute liver failure. And with her MELD score going so high, um, that really was the trigger for us to send her over to a liver center to get evaluated for transplant. But really, for, I think the big thing that the reason why I wanted to present this case is that I made a I had a bit of a sort of late diagnosis and sort of lack of recognition of, hey, your serum lactate is greater than 20, and it's still up even 4 hours later, despite resuscitating them appropriately. You got to think of something else. And not only that, this is a patient who definitely needs the ICU. This is a patient that I had admitted when I was on my month of inpatient wards nights, where we're essentially an autonomous hospitalist and we're covering patients who are, in the general wards or in step down level of care.
Hey, Drew, can I just
But
for 1 second? I really apologize. I'm so sorry. I want everyone to keep hearing your reflection. So I was just gonna jump in to say that I made our teaching points guru Francisco the host. I have to run to rounds, so I'll
yeah,
catch the remainder of your reflection later. So please keep going as much as you like, and then
yeah,
Francisco, I made you the host. So when you're done with your teaching, please feel free to end the meeting. Thank you, guys.
yeah. All right. Yeah. Um, just to really quickly say that recognition of the fact that the lactate was not going down, I think was something that would have made me think, oh, this patient actually needs to be in ICU level of care, not admitted to a hospitalist level of service. So with that, I'm gonna turn it over to Francisco to go over the teaching points. And yeah, thank you guys so much for letting me present this.
Oh, great case, Drew. Like, this is a very humbling one. Learned a lot. Um, you really did your best to take care of this patient, and indeed it was an unfortunate event. And so we when we starting the teaching point, which we start with the chief complaint, but I can't emphasize enough what Rabih said, that actually this case started 6 years ago when this patient developed cirrhosis when She was 24. But here we start off by asking ourselves, what is the problem? This is a complete chaos. So the patient presents with past medical history of pancreatitis, diabetes, cirrhosis, but we have to be very objective. Cirrhosis and diabetes dominate, and we are talking about two diseases that can be genetic, of course, but in this case, in given the social history of the patient, we have to think, okay, alcohol and cirrhosis. The patient is 30 years old, of course. It can be a cause, but we have to think about masqueraders, keeping always an open mind. And then we have to think, okay, alcohol and diabetes, how can a young patient have it? And in this case, it was due to chronic pancreatitis. And it's very important to have a point of care glucose whenever a patient has not only abdominal symptoms, but also neurological symptoms. And the patient indeed was in DKA. So what is signal and what is noise in this very rich case? So we have to confirm our history findings with the physical exam. And what stands out is the decompensated cirrhosis, where Rabih said that in this case we don't designate it acute liver failure because patients with cirrhosis don't have really hepatocytes, so we call it decompensated cirrhosis, and we have to think about GI bleed and portal vein thrombosis in these patients. And here, the patient was also clearly anoretic, and when there is nothing where we makes a suspect of anorexia, we have to get an HIV. But here, the patient has these pancreatitis, cirrhosis, and diabetes, so clearly explaining the anorexia. So even though it worries us, we have evident causes. When patients have diabetes type 1, they have complete insulin deficiency, they have ketone formation and abdominal pain, and get symptomatic way before when patients with type 2 that have ketosis much prolonged in time later in the course of the presentation. So the patient then we got to the vitals and to the physical exam. She was hypothermic, and we have to think there are two ways of thinking: either environmental and infection, or temperature generation problem or loss. The patient meets criteria for sepsis, and and we should warm the patient, give insulin, fluids, antibiotics, cultures, and then we get to the lab. So what is the main abnormality? Everything else, all the other abnormalities are explained by the past medical history of the patient. Here, as also Drew highlighted at the end, what is really the main abnormality? The high lactate, refractory to the fluids. And then, so we start to think about lactic acidosis, which can be type A, type B. Type A is, we can call it hypoxic, and type B, the non-hypoxic. And it can be focal to like mesenteric ischemia. There's production of lactate. Hypoperfusion, which is a more systemic problem, or methylhemoglobinemia, or carbon oxide intoxication. And then we have the type B, which is associated with high metabolic demand, mitochondrial problems, thiamine deficiency, or a high glycolysis state where a patient has like a beta agonist. We also have to pay attention to false positives like the ethinyl glycol. It's an ABG error. And when we think about pneumatosis, and this is really the crux of the cases, we may have some benign causes, or bowel wall is compromised, and we have to think about the two I's: infection and ischemia. And here, when we have to think about ischemia, most likely infection will be present. So is it a cause or a consequence? We have to treat it. That's what matters. And then we have mesenteric ischemia, where we started to lean towards that, and it can be arterial or venous, and we have to do a CD protocol for venous and arterial phases. It's a disease that can be very commonly missed. if we don't specify in our reports that we are looking for it, actually can be overlooked in 25% of cases. And yeah, the crux of this problem was really on the lactate being disproportionately high. So I'd like to thank everyone for being here. Dhruv, it's always a pleasure to have you. Thank you, Tansu. It was a hard case in terms of scribing. And happy Friday, everyone, and have a good weekend.
Same to you guys.
Thank you.